Thank you so much for the opportunity to talk with this group today. I'm so glad to be here to tell you about our work through the International PPB Dicer-1 Registry and the International Ovarian and Testicular Stromal Tumor Registry. I'm Chris Ann Schultz. I'm a pediatric oncologist at Children's Minnesota and principal investigator for the registries, which we'll be talking about today. And my title today is From Bedside to Registry and Back Again, in recognition of the critical role that bedside to bench and bench to bedside work has in improving outcomes for children with rare tumors. There are standard Children's Minnesota disclaimers and confidentiality protections. The main one for today's talk is that some of the data I'll be presenting is not yet published and thus should be taken with the proverbial grain of salt. Our agenda today is to discuss a whirlwind tour of PPB and the PPB Dicer-1 Registry, to review our mission and strategic pillars, to talk about the nuts and bolts of registry work and registry research, and discuss some of the opportunities and challenges that we've faced in this work and how that may inform future research. The story of PPB is really the story of children and families, and this story really starts here in the late 1980s when a 2-year-old girl presented to the hospital, Children's Minnesota, with pneumothorax, which is air between the lung and the chest cavity. She was having difficulty breathing and therefore had a chest x-ray performed, followed by a CT scan of the chest, which showed a cystic lung lesion. And by imaging, this cystic lung lesion appeared to be a benign and fairly common entity called CPAN. She was taken to the operating room and this lesion was resected, but to everyone's surprise, under the microscope, it appeared to be a malignant lesion. And you'll see here these images, blastomatous cambium layer with anaplastic cells and sarcoma botryoides, and below, anaplastic stroma, suggestive of rhabdomyosarcoma morphology. So here was a tumor which looked like a benign cyst by imaging, but contained a malignant component analogous to rhabdomyosarcoma. This child did well. She was treated with 42 weeks of chemotherapy with vincristine, actinomycin D, and cyclophosphamide, and everything seemed to be going fine until a short while later when her younger brother came into the hospital also with respiratory distress and was found to have what appeared to be a more aggressive version of this same very rare lung tumor. And based on this early sentinel observation of this now, what we now call pleural pulmonary blastoma, found in 2 siblings, the International PPB Registry was formed. So the registry was formed in 1987 to study PPB, pleural pulmonary blastoma, which we now recognize as the most common form of lung cancer in infancy and early childhood. And these are very young children. 92% of clinically significant PPB is diagnosed in children less than 7 years of age. Like other sarcomas, the malignant component derives from lung mesenchyme. And we recognize 4 main types of PPB, the first 3 of which are represented at this point on this slide. Type 1 PPB is a purely cystic lesion, but don't be fooled. It's an air-filled cyst, but the lining contains a layer of primitive malignant cells. This is diagnosed at a median age of only 8 months. If those malignant cells continue to grow and proliferate, this forms a mixed cystic and solid lesion we term type 2 PPB, diagnosed at a median age of 36 months. And if those malignant cells continue to grow and proliferate, forming a purely solid lesion, shown in the third panel, we term that type 3 PPB, diagnosed at a median age of 41 months. And we see this progression both in the age of diagnosis and underneath the microscope and by imaging. But we know that progression is not the universal fate of all PPBs. And in fact, we recognize a 4th type of PPB, type 1R, regressed or non-progressed PPB, which is an air-filled lesion lacking a malignant component. So again, type 1R PPB, perhaps the most common form of PPB, is a regressed or non-progressed form, which may be diagnosed at any age. And for older individuals, this is often the age at their first chest imaging, with a representative CT scan shown here showing a small cystic lesion. As this initial story illustrates, from the very early days of PPB, there was evidence for familial predisposition. And this family tree, or pedigree, is shown from a different family, showing 2 brothers, one age 2 and one age 4, diagnosed with type 1 and 1R PPB respectively, whose maternal grandmother had a history of thyroid nodules removed in childhood, a pituitary prolactinoma removed at age 25, and a Sertoli Leydig cell tumor, a very rare tumor of the ovary, diagnosed at 32 years of age. Based on family trees like this, additional study was performed, including a linkage analysis, the results of which were published here in Science, showing Dicer1 mutations as the underlying genetic factor in familial pleuropulmonary blastoma. And I'd really like to highlight from this paper published in Science that this was originally recognized just in 2009. So we're still very early in our understanding of PPB and Dicer1. And yet so much has been accomplished thanks to the power of. We now recognize a spectrum of Dicer1 related conditions, including but not limited to PPB, with potential manifestations in nearly any organ system, including brain tumors such as pituitary blastoma, pineoblastoma, and CNS sarcoma. In the eye, we recognize a rare tumor called ciliary body meduloepithelioma. In the nose, nasochondromesenchymal hematoma. In the thyroid, we see thyroid nodules and thyroid cancer. In the lungs, PPB, as mentioned previously. In the abdomen, there's a more recently recognized tumor termed PPB-like peritoneal sarcoma. In the kidneys, we see cystic nephroma, rarely Wilms tumor, and renal sarcoma. In the small intestine, rarely juvenile polyps. And in the genitourinary system, especially in girls, Sertoli Leydig cell tumor, gynandroblastoma, and ovarian, uterine, and vaginal sarcoma. Based on our interest in the genitourinary manifestations of this, an additional registry, the International Ovarian and Testicular Stromal Tumor Registry, was founded in 2011 in parallel to the PPB Dicer1 registry. Based on our evolving understanding of PPB as linked to a variety of Dicer1 related conditions, the name and the mission of the International PPB Registry has expanded. So it's now called the International PPB Dicer1 Registry and has enrolled more than 1,000 individuals. Eligibility criteria includes individuals of any age with suspected or known PPB or other Dicer1 related conditions, or germline pathogenic Dicer1 variation or mosaicism. Importantly, the registry offers free central pathology review, which we feel is key to the integrity of research results, especially in rare tumors, as up to 20% of cases sent to us as pleuropulmonary blastoma are found to have an alternate diagnosis on central review. Registry participants include individuals mostly from the United States in 47 states, but also include individuals from 49 countries around the world. The mission of the PPB Dicer1 registry is to improve outcomes for children and families affected by PPB and other Dicer1 related conditions through 4 strategic pillars. Number 1, to define optimal therapy for these tumors. Number 2, to validate testing and surveillance guidelines. Number 3, to develop new ways to diagnose and follow children with Dicer1 related cancers. And number 4, to develop new therapies for Dicer1 related cancers. Strategic pillar number 1 is to define optimal therapy for PPB and other Dicer1 related conditions. Most children with type 1 PPB do well, but we want to understand how best to optimize those outcomes while reducing the potential side effects of chemotherapy. Particularly, we want to understand which children will be cured by surgery alone and which children require chemotherapy. When lung cysts are detected in children or adults with Dicer1, we want to understand which lung cysts truly require surgery and which lung cysts may be safely observed. Unfortunately, the prognoses are much less favorable for type 2 and type 3 PPB than for children with type 1 and 1R PPB. And therefore, for type 2 and type 3 PPB, we need to understand, in addition to intensive chemotherapy, which children also require additional treatment intensification with radiation or potentially with other novel therapies. For individuals with Sertoli Leydig cell tumor, the rare ovarian tumor we talked about earlier, we wish to understand which individuals require chemotherapy and when giving chemotherapy, which regimen is best. And for all the Dicer1 tumors, really, we need to understand the optimal treatment regimens, both for primary disease and for recurrence. An example of one of these analyses is shown here. We included 550 children with centrally reviewed PPB, including 230 with centrally reviewed type 1 or 1R PPB as their first diagnosis, and then limited that cohort to children diagnosed from 2006 to 2021. We analyzed outcomes related to surgery plus additional upfront chemotherapy versus after surgery alone, and happily found that the overall outcomes were favorable. Those 7 children who received only surgery either experienced regrowth or progression to type 3 PPB. Likewise, we used the data in that analysis to analyze our approach to lung cysts. We have found there's a high likelihood of finding lung cysts in individuals with DICER1, and unfortunately type 1 and 1R are similar in appearance by imaging, although they're quite different under the microscope. Type 1R has no malignant cells, and type 1 does contain malignant cells. So we use the data I just told you about to generate a heat map, including age at diagnosis, age at detection of that cyst, and largest cyst dimension to predict the probability of type 1 versus 1R. In type 2 and type 3 PPB, we really need to understand how to improve prognosis. And so our current analysis focuses on 131 children treated with an initial and quite intense regimen of ifosfamide, vincristine, actinomycin, and doxorubicin. These children had metastatic disease at diagnosis in 4% of individuals with type 2 PPB and 14% of those with type 3 PPB, and received neoadjuvant chemotherapy prior to full resection in 32% and 61% of these children, respectively. The PFS and OS numbers are shown here, showing that children with type 2 PPB have a more favorable prognosis compared to children with type 3. Unfortunately, despite their intensive treatment regimen, distant recurrences, especially in the central nervous system and in the latter portion of IVIDO chemotherapy, represented a significant number of events for these children. So our key goals in PPB are now clear. For type 2 and type 3 PPB, we need to maintain upfront tumor reduction and optimize local control while also reducing the risk of local and central nervous system metastatic disease. And for type 1 PPB, we need to maintain the favorable outcomes that we see in this group, but reduce chemotherapy exposure and toxicity as much as we safely can. And of course, for all types of PPB, we'd like to develop novel therapies. Pillar 2 is early diagnosis, which is key to improving survival. So for type 1R, PPB-related survival is 100%. For type 2, 5-year PPB-related survival, 89%, which decreases to 71% and 53% for type 2 and type 3 PPB, respectively. So early diagnosis is key to improving outcomes, both survival outcomes, but also in reducing the risk of late effects. As I said, type 1 PPB may be treated with complete resection, sometimes with and sometimes without chemotherapy. And we do not observe any metastatic disease unless there's first progression to type 2 or type 3 PPB. Children with type 1R are treated with resection or observation, depending on the clinical circumstance, whereas children with type 2 and type 3 PPB are treated with intensive chemotherapy with or without radiation and remain at high risk for chest and brain metastatic disease or recurrence. So this is an example of early diagnosis in action. This is the story of a 33-year-old young woman who self-referred to the International OTST Registry due to her own history of sertoli late cell tumor many years prior. And I remember my initial consent conversation with this woman. She said something along the lines of, I mean, if my old tumor sitting in a jar somewhere could help someone, of course, I want to do that. So her research-based testing showed DICER1 germline variation. And I remember feeling terrible about calling her to tell her this, knowing that she was pregnant with her third child. But based on that finding, the child was tested at birth, was found to have a type 1 PPB, which was carefully resected with no sign of spillage. That type 1 PPB did have some features of early transition to type 2 PPB. However, based on the way that the surgery was done, carefully resected with no spillage, he was treated with surgery alone without chemotherapy, and is now doing absolutely beautifully well. Just demonstrating really that knowledge is power. We found this tumor because we knew about his risk factors and were able to do surveillance, preemptive surveillance. So how do we get there? Well, testing is really key to early diagnosis. So we now have defined indications for DICER1 testing. And we also have surveillance guidelines established. Once you detect DICER1 germline variation, what should you do next? What should you talk to families about? What symptoms and signs should treating physicians know about in advance? And so these are the guidelines by organ system. I should say, though, that I don't think these are the be-all end-all of surveillance. I think there are many different ways to approach surveillance, and really what we need to do next, now that these are available, is validate these, figure out which pieces of these surveillance algorithms are most important. We also need to understand how to detect these tumors better. Some of the surveillance testing that we currently recommend includes radiation or requires sedation for young children. So I think it's really critical to always be thinking about new and better ways to detect these tumors in their earliest and most curable form. And cancers do give us some potential opportunities for that. Likewise, we need to develop novel therapeutics. There are few established treatment options for children with recurrent PPB and high rates of central nervous system metastatic disease. So we have active PDX programs testing conventional and novel therapeutics, in addition to our analysis of patient charts to try to understand the best treatment options for these children. So we've got big needs, and we've got big dreams and big challenges, like this group, like the group in the audience here. So what are some take-home messages? What can we take from the registry experience to guide research going forward? Well, I think the first critical step is you need to decide where to go. What are the greatest needs for the individual patient population that you hope to serve? And what do you need to do to get there? Especially, I think it's worth considering what already exists and where the critical gaps are as you decide on the best infrastructure to address these critical needs. So some of the potential considerations, of course, are development of a biorepository, development of a registry, versus use of existing data sources and repositories. And of course, each route has both opportunities and significant obstacles associated with it. There really are big advantages to a registry infrastructure, and I just feel so grateful to get to work with both of these registries, the PPB DICER-1 registry and the International OTST registry, as well as to learn from collaborators at other rare tumor registries around the world. But a registry is not the only way to do cancer research, of course. So it's worth considering whether you really need a registry and what other infrastructural mechanisms may work, especially whether there's anything already in place that could help. Registries do offer the advantage of longitudinal data collection, and a huge advantage of a registry mechanism is to truly involve patients and families. The participants in this research ask such insightful questions. They have a truly unique ability to engage with one another and to engage with the community, and really bring not only their own tumor journey specific expertise to the table, but also they bring all of their expertise to the table, what they do in their professional or personal lives, in addition to their health journey. And we've really found that to be just so incredibly important and valuable in registry research. So I feel so fortunate to get to work with this community through this registry mechanism. And no matter what infrastructural plans are ultimately developed for the future of this research, I think considering how to involve the voice and the expertise of patients and families is really key. Once you decide on your mechanism, you need to start with the most important questions and build that mechanism or gather that mechanism to collect the key data that you need. Obviously, you can't collect it all. Your time is precious. All the researcher time is precious, but also the participant time and the time of the treating institutions that currently have the records. The time of all of those individuals is so valuable that I really think it's important to collect what you need, but not to collect only to collect, and to try whenever you can to avoid unnecessary duplication of efforts. There's only so much time, there are only so many resources, and you want most of that time and resources to go to the actual work, not just development of the infrastructure to support that work. Registry infrastructure, of course, comes with big challenges related to IT, database development, data security, legal elements, and privacy. Rare tumor research includes many international benefits and challenges. It's certainly wonderful to work with our international community, but that does introduce some logistical challenges when it comes to, especially to data sharing. The more patients are included from the more far-flung places, the more treatment is heterogeneous. That's already an issue with rare tumors at baseline, but adding in many different institutions, of course, increases that complexity. And then, of course, in any setting, in rare tumors, we should try to be as inclusive as possible, and that does introduce the potential for language barriers. And our personal feeling, my personal feeling is that whatever we can do to diminish the language and other barriers to participation is really critical. And so our registry currently has set forms in English, Spanish, Arabic, Italian, German, and French, and working to add additional languages as well. That, of course, though, comes with its additional logistic and financial challenges, which we're currently working to continue to navigate as we add additional languages. So what does it take to do this? It certainly takes a critical mission, and you have that. It takes, thank you, Margaret Mead, a small group of dedicated individuals, truly collaborative interactions, both here and abroad. It takes time and funding, and I really believe it takes all of us working together to make this work. So registry is certainly not the only way to get it done, but here's some things that I feel I've learned through working with the registry. Really the biggest one is to not start with the goal of developing the registry. The goal is never to develop the registry. The actual goal is to, in our example, it would be to understand the best treatment for type 1 PPB, or to increase the survival rate for type 1 PPB while decreasing chemotherapy exposure, for example. So starting with those actual goals will guide what needs to happen next. The goal is not to develop the registry. The goal is the actual goal. I think it's really important to sketch out multiple routes of entry to participation, whether that's the routes that data will flow or the route the participants will use for consent, depending on the mechanism you choose. Of course, considering how to integrate online elements such as online enrollment and online data submission while keeping in mind all those other challenges is really important. I think it's helpful to consider data visualization and outlier analyses. For us, that means considering which of the highest risk children survived and how. And then, as I've said, to really involve families and treating clinicians directly, not as mainly as information sources in terms of their medical records, but really in terms of contributing their expertise and their insights. So again, start with the end in mind. These are the CRF hard knocks. Start with the end in mind. Decide on your data collection strategy early and rarely. These are tongue in cheek now. Revise as needed, but never revise. You know that. And design your data collection to collect discrete data with free text field options for new or unclear or emerging data. And of course, opposite of that, to never use free text fields. But really, of course, what I'm saying here is to try to balance these conflicting ideas as best as you can in the real world of data collection. And when it comes to CRFs, to especially consider who will fill this out, who will be submitting the data, and then of course the when, why, and how of all of that. For us at the registry, that's meant that we, for the most part, collect the actual treatment records and the actual chemotherapy roadmaps, and we abstract them ourselves. That gives us the most uniform data collection. But there are instances where the records are in a language that we don't feel we can correctly translate. And so in those instances, then we look for help from our international collaborators in terms of helping us fill out the CRFs directly. So for us, it's a hybrid option, but certainly something to consider with regard to data collection. And then thinking early about how you'll validate the entered data, especially in rare tumors. Each data field really matters so much that you want to make sure that those fields are as correct as they can. I've said this before, but I'd really like to emphasize again the importance of outreach. The registry is primarily a research organization, but we think outreach is a key part of what we do. Therefore, we host an annual scientific symposia for health providers and researchers, in addition to family meetings. The most recent one held August 5th, just a couple months ago, and the next one planned for August 4th of 2022. We share research information as well as enrollment information on the registry websites through Facebook and Twitter, and then seek input both informally and more formally through the Patient Parent Advisory Board, and then have a Youth Advisory Board pending. And of course, we've added these onto our protocol over the years through amendments, but if starting from scratch, I think designing a protocol in sense with all of these ideas in mind can be really helpful. When it comes to international considerations, international work is of course critical to advancing rare disease research, but it's quite complicated. This work would benefit from more harmonized definitions. Again, the inclusion of central pathology review and concordant data collection, the inclusion of molecular markers where possible, and then of course lots of help with varying privacy and research laws. That for us has required a recent amendment to our protocol to accommodate the different potential logistics, and thinking carefully about who will abstract the data in the international setting and any language or translation considerations. And of course, the regular heart-to-hearts with chief information security officers to make sure that all of that is done. I think in pediatric and adult research, considering end-of-life contributions is really important. And then thinking about how we can help families and help really recognize that immense contribution of participants who contribute tissue or data at end of life. Planning ahead for how that information and how the great contribution their loved one has made can be fed back to the family. How can we give that information back to families after a child or a loved one dies? And how do we follow up with families regarding what has been learned from their loved one's contribution? I think that's a really important piece that we should plan ahead for as we design new research. So cancer research is a team sport, and I'm so grateful to work with such a wonderful team. I hope that all those folks in the audience will think about PPB and DICER1 when they think about rare tumor research, and certainly connect with us with any questions regarding it. I'd like to highlight here again at the end the importance of central review. This is something that's been a standard part of registry procedures since its inception. I really think has contributed to the integrity of the research data. We're very fortunate to be able to perform that at no cost to the family or hospital. And then if fresh tissue is available at the time of surgery, we also use that in vitro or in vivo models to help with development. So in terms of take-home points for today, again, I think the goal is not ever to develop a registry. The goal is really to do the actual goal. And if a registry is the mechanism needed to accomplish it, then that's great. I'm certainly happy to chat with anybody about the logistics that we've encountered. The other take-home point is really about the power of kids and families and what our obligations are then in return for the enormous contributions of kids and families to this research. And then importantly, that interesting is not enough. Science is totally fascinating. Pediatric oncology is totally fascinating, but that's not really what it's all about. It's really about the true goal of better outcomes for kids and families. And this is the survival curve for children with recurrent type 2 or type 3 PPB. This is PPB. This is the reason we do what we do. We have a long way. We've come a long way since 2009, and since 1987, but we clearly have a long way yet to go. Our hashtags for the I'm no social media guru, but nowadays you got to have hashtags, right? So our hashtags are every journey matters in earliest and most curable form. And we invite you to visit our website, learn about testing, surveillance, treatment, and the latest DICER1 research to connect with us and consider getting involved. Our goal is really to serve as a resource, spread the word, facilitate collaborations, and accomplish those strategic pillars together. So the quote from the expert at the European Rare Tumor Collaboration: if you study common tumors, run randomized double-blind placebo-controlled trials. If you study rare tumors, find friends. And in the words of one of the moms, one of my beloved patients, all the pieces are there, but it's up to us to work together to put them together. So with that, I wish to thank our many collaborators, both here in the United States and around the world, and our registry team partners and NIH NCI partners. And to thank Dr. Leslie Doros for the kind invitation to speak today. And thank you to the many kids, families, and clinicians who collaboratively support DICER1 research. Thank you.